sir.
Yes, good morning everybody, and I also am thankful to Bansi Sabu for organizing one more episode of endocrine, diabetes and metabolic programs, and we are lucky that this thing is happening every year in the month of September. So I have been given a very interesting topic, hyperthyroidism, management in diabetes. See, hyperthyroidism is a very, very common entity, much more than what we think and what we know. And we must be missing out many of the patients who are having hyperthyroidism. And this combination, hyperthyroidism and diabetes, is also quite common. And managing this dual problems, hyperthyroidism along with diabetes, at times is a challenge, difficult, and also at times very, very interesting. So I begin with a case. This lady who is 47 years old now, she has history of weight loss of about 5 kg, and in spite of increase in appetite, and she has also protrusion of eyeballs recently. And then she had this history of having type 2 diabetes since 2.5 years. Her HbA1c was meticulously managed by a very, proficient internist, and with this medication, glimepiride 1 milligram and metformin 500 OD, her HbA1c was fantastic, 6.2. And then after some time, she had this weight loss history and protrusion of eyeballs, and her A1C increased to 8.7%. Of course, fasting PP increased, and she was diagnosed to have high T3, high T4, low TSH. Her TSH receptor antibody was moderately severely positive. She was diagnosed to have deterioration of glycemic control due to hyperthyroidism, and since she has exophthalmos as well as positive TSH receptor antibodies, she was diagnosed to have Graves' disease with hyperthyroidism. Of course, this astute clinician, she increased medication to control her diabetes to with one glimepiride metformin twice a day, and introduced carbimazole 30 milligram per day. On follow-up, after 3 months, her A1C again got normalized, her TFT got normalized, but again 4 months later, this good-looking lady had aggravation of her exophthalmos, and she was seen by an ophthalmologist because she had diplopia, and so she was prescribed steroids. Of course, this was oral. There are lots of protocols, but because of convenience, she was given oral steroids. But this aggravated her diabetes, and her diabetes was, her fasting post-breakfast and post-lunch was very high, with normal fasting blood sugar with the medication she was taking. So she was referred to me, and I had to start insulin before breakfast and before lunch. We have to be very smart, because if we give conventional insulin, they are likely to develop severe hypoglycemia during night and in the morning. So again, she was made euthyroid. Her exophthalmos diminished to some extent, not fully, but she was better. And she is currently euthyroid with 10 milligram of carbimazole and glimepiride 1 milligram plus metformin 500 milligram BD, which was earlier only 1 milligram 500 OD. So thyroid disease and diabetes, this jugalbandi is not very uncommon, not rare either. There are many possibilities. Type 1 diabetes can have hypothyroidism, type 1 diabetes can have hyperthyroidism. A type 2 diabetes patient can have hypothyroidism, which is very, very common, and type 2 diabetes patient can have rarely hyperthyroidism, as it has happened in our case. And once these two conditions happen simultaneously, one can aggravate the other, and the other can aggravate. There is a bidirectional relationship. Of course, the impact of thyroid dysfunction, that is particularly hyperthyroidism, will be more on diabetes other than diabetes having effect or impact on thyroid dysfunction. So what is the prevalence of thyroid dysfunction in diabetes? It is not so uncommon. So among type 2 diabetes patients, the prevalence of thyroid dysfunction is 20 to 24%. So 1 out of 5 or 4 patients with type 2 diabetes is having one or the other thyroid disease. This can be hypothyroidism, this can be hyper. Of course, hypothyroidism is much more common. If we combine both subclinical hypo and overt hypothyroidism, it is roughly 20% of patients with type 2 diabetes, they are having hypothyroidism. And hyperthyroidism is also not very rare, almost 2.5%. So that means 2 out of your 100 type 2 diabetic patients which you are going to see, and many of busy clinicians, they must be seeing 100 type 2 diabetic patients in 3 months. So they must be seeing 2 hyperthyroid. This is what I conclude. And this is a study which was done in Spain, a very large population study which showed that now the other relationship, what is the impact of diabetes in people with thyroid dysfunction. So again, this study which showed that hyperthyroidism is more common in diabetic patients, about 70% higher, and also roughly 70% higher in type 2 diabetes. So thyroid dysfunction leads to both disturbances and disruptions in diabetes, and diabetes can also lead to hyperthyroidism and hypothyroidism. Now our topic, the hyperthyroidism, what is its impact on diabetes or hyperglycemia? Thyroid hormones, as you know, is catabolic hormones, and it increases glucose production from liver, muscles, and there can be hyperglycemia. If there is hyperthyroidism, they also have some impact on resistance on insulin, and that leads to, in totality, if it is not under control, then it can even lead to diabetic ketoacidosis. And if diabetic ketoacidosis can also impact on thyroid dysfunction, and it can lead to thyroid storm. So if these two conditions combine, of course, it's very, very rare to have diabetic ketoacidosis and thyroid storm, but these two can be very, very lethal, and it can also lead to very high amount of morbidity and mortality. But a type 1 diabetic patient is very vulnerable if he or she develops severe hyperthyroidism all of a sudden, and which is not checked, and it can lead to diabetic ketoacidosis. Now, what are the adverse outcomes of coexisting hyperthyroidism and diabetes? If suddenly a man or woman develops hyperthyroidism in the background of diabetes, of course, as it happens in our patient, there was worsening of glycemic control. They also have increased chances of hypoglycemia. I think in Dr. Rakesh Shah's talk, it was discussed in depth about Hirata disease and problems related to hypoglycemia. We will also touch upon some clues related to this. So some of these patients are having more chances to develop hypoglycemia. And mainly a diabetic patient who is regularly treated, he or she becomes more vulnerable to develop hypoglycemia when she develops hyperthyroidism, and which is being under control. There are more chances of cardiovascular disease, because these two diseases, they can both, this patient with diabetes is already having some cardiovascular predisposition, and with presence of hyperthyroidism, it can lead to atrial fibrillations, and also it can lead to, it can precipitate angina, etc. So they are more likely to develop cardiovascular problems. Of course, the chances of microvascular complications are also high. So controlling hyperthyroidism in diabetes is very, very important. And although there are not much differences in treating hyperthyroidism in a patient with or without diabetes, but we have to be a little careful while managing diabetes in patients who develop hyperthyroidism, because there can be lots of variation in thyroid function, which can also change the metabolic milieu, and also we need to adjust anti-diabetic medications accordingly. So what should be the goals and the challenges? We need to achieve euthyroid state, and it should be maintained, because hypo-hyper in terms of thyroid dysfunction can also have a negative impact on diabetes. We need to minimize metabolic derangements, we need to reduce insulin resistance, and also we need to prevent acute complications and of course chronic complications. We need to know the drug-drug interactions, and we need to know the impact of antithyroid therapy on liver and other problems. So how to manage hyperthyroidism in diabetic patients? Although, as I said, there is not much change or differences in treating hyperthyroidism in diabetic patients versus non-diabetic patients, but again we have to be a little careful and smart to see the impact on diabetes, because once you control hyperthyroidism, there can be change in glycemic control, we commonly use, of course, this is a very long topic, how to choose one way of treating hyperthyroidism, antithyroid, radioactive iodine versus surgery. But to suffice that currently maximum all the hyperthyroid patients are treated with antithyroid medications, rarely radioactive iodine, and very, very rarely with surgery. So that applies to patients with diabetes also. And we had very long and in-depth discussions on methimazole causing hypoglycemia. We will also speak a little bit on that. Carbimazole and methimazole, they are both same. Carbimazole is a prodrug for methimazole. Carbimazole is metabolized to methimazole. In fact, this is commonly prescribed in our country, whereas methimazole is prescribed in US and Europe. So they don't know much about carbimazole, but they are the same. Of course, the potency-wise, carbimazole is two times less potent than methimazole. So if you see sudden worsening of diabetes, you should think of hyperthyroidism, and it must not be missed. Particularly, this is more common in type 1 diabetes, and it can be easily missed out because they are already underweight and also they are having anxiety. But in type 2, it may be distinguished. And all hyperthyroid patients, they don't have exophthalmos, so don't wait for protrusion of eyeballs to suspect hyperthyroidism. So with this, I lead to another interesting case. This gentleman who is 45-year-old, whom I was seeing since about 7 or 8 years, coming from all the way from DISA, and he had hyperthyroidism since 7 years, and he was on carbimazole 10 milligram per day. And with this, he was maintaining euthyroid, and then suddenly he had repeated episodes of hypoglycemia. His HbA1c was 7.2%, and he had, he was not on any anti-diabetic medications, and without that, he was developing hypoglycemia. And as it was discussed what is the role of HbA1c in hypoglycemia, you can see that even without any anti-diabetic medications, he was developing hypoglycemia, and his HbA1c was 7.2%. He was prescribed acarbose 20 milligram TDS, and still he continues to have hypoglycemia. We investigated, and he was found to have no adrenocortical insufficiency. His TSH receptor antibody was mild positive, confirming Graves. GAD was negative. We suspected he might be having early type 1 diabetes, and then insulin antibody was done, and it was found that he had positive insulin auto antibodies. Hirata was confirmed, and then of course there is no medication. We give steroid, and steroid was slightly contraindicated because it would have aggravated his diabetes. And this is the mechanisms of Hirata disease. There is some groups present in carbimazole which can lead to formation of insulin antibodies, and this leads to hypoglycemia. So whenever you see a patient with hyperthyroidism and diabetes, it's very imperative that we restore euthyroidism as quickly as possible, so as to, I will take just a minute, and this will definitely help better control of diabetes. And we need to have good glycemic control. This can be done with conventional ways, and if you are not able to control, then we should not hesitate to use insulin. Many of the patients, when they develop hyperthyroidism, they are very well controlled with current medication, and then suddenly you are unable to control, and then that time you need to start an insulin. And in case, as it happened in patients with Graves' disease with exophthalmos, you need to give, and if patient is being given steroid, you need to start insulin and adjust insulin. Once patient becomes euthyroid, again you need to have very quick adaptation to prevent hypoglycemia. So euthyroidism restoration is very, very important, which can improve his or her diabetes control. And this has been shown that any way, any method through radioactive iodine or medications, if you control diabetes, you can if you control hyperthyroidism, there will be improvement in diabetes as well. We should not forget the other associated complaints with this dual problems like significant weight loss, muscle weakness, and tachycardia. They are more likely to have cardiac problems, electrolyte imbalance, and of course osteoporosis. So whenever we see a patient with hyperthyroidism and diabetes, we need to be aware about hypoglycemia risk because of medications, and also because of change in thyroid function which can have impact on metabolic problems of diabetes. We should be careful for agranulocytosis, although it is not very common. PTO can cause hepatic injury or even carbimazole, and this is very important. Many diabetic patients, they undergo some of the investigation which requires iodine, and this iodine can aggravate hyperthyroidism, and this can lead to sometimes thyroidostoma, etc. These are the some, they are just experimental things, and this anti-diabetic medication can have some impact on thyroid, but these are not confirmed in clinical or human beings. So to summarize my talk, hyperthyroidism acts as a potent insulin antagonist leading to refractory hyperglycemia and a high insulin demand. If you see your next patient not able to get good control, particularly in type 1 diabetes, think about hyperthyroidism. This may be a cause. Screening for thyroid dysfunction should be a standard practice in all diabetic patients. I already highlighted that 1 out of 4 or 5 diabetic patients are having some thyroid dysfunction, mostly hypothyroidism. So you have to, there are some guidelines, they suggest that annual screening. And once you see a patient with hyperthyroidism, you need to have immediate control to prevent any complications. And we need to adapt insulin or OHS according to the phase of hyperthyroidism. Thank you very much for your patient hearing.
Thank you.